Hello, my name is Peter Lawrence, and I'm pleased to introduce the April issue of the Journal of Vascular Surgery, and to highlight 4 outstanding papers which are freely available for the next 2 months. Our editor's choice article for this issue is called "The Association Between Surgeon Case Volume and Years of Practice with Open Abdominal Aortic Aneurysm Repairs," and this paper is by Scully and co-authors. Endovascular aneurysm repair has led to a decline in the use of open aneurysm repair, but little is known about the interaction between open abdominal aortic aneurysm case volume and surgeon experience. All infrarenal abdominal aortic aneurysm open repairs in the Society for Vascular Surgery VQI Vascular Quality Initiative from 2003 to 2019 were examined. Practice experience had no association with unadjusted mortality. However, more experienced surgeons had fewer complications after elective open repairs. That is 25% with 16 years of experience versus 29% with 5 years. Increasing surgeon experience was also associated with a greater proportion of elective open repairs. Low volume surgeons had inferior outcomes compared with high volume surgeons, and high volume early career surgeons had outcomes similar to those of older low volume surgeons. The authors concluded that annual case volume appeared to be more important than cumulative years of practice. The second article this month is entitled "Lipoprotein A Levels and Risk of Abdominal Aortic Aneurysm in the Women's Health Initiative" by Chow and colleagues. They evaluated the association of lipoprotein A levels with the risk of abdominal aortic aneurysm in women using the National Women's Health Initiative, since previous smaller studies had shown a relationship. The mean age of the 6,615 participants was a little over 65 years. Those in higher quintiles of lipoprotein A were more likely to be overweight, Black, and or current smokers, to have hypertension, hyperlipidemia, and a history of cardiovascular disease, and to use menopausal hormonal therapy and statins. During 10.4 years of follow-up, 415 women were diagnosed with an abdominal aortic aneurysm and 36 required intervention. More than one-half had a ruptured abdominal aortic aneurysm. However, the authors failed to find an association between lipoprotein A levels and the occurrence of abdominal aortic aneurysms. The next article is by Ashrina and colleagues and is entitled "The Safety of Vascular Interventions Performed in an Office-Based Lab in Patients with Low to Moderate Procedural Risk." An exponential increase in office-based vascular procedures has occurred in the United States since 2008, so the authors assessed the safety of these procedures. Over a 4-year period in their institutions, 6,201 procedures were performed in 2,779 patients. The procedures were categorized into Group 1, which were venous procedures, Group 2, which were arterial procedures, Group 3, which are arteriovenous procedures, and Group 4, which are IVC filter procedures. Local anesthesia, analgesics, and conscious sedation were used in all interventions, and they were individualized to patient and the procedure performed. Arterial closure devices were used in all arterial interventions. The mean age of the study population was 66.5 years, 67% were women, and 33% were men. 5,783 venous procedures were performed, including vein ablation and iliac vein stenting. 238 arterial procedures of the femoropopliteal, infrapopliteal, and iliac arteries were performed. 29 arteriovenous accesses and 51 inferior vena cava filter placements were performed. The majority of the procedures were ASA2, and a total of 18.5% were ASA class 4. There were no mortalities, major bleeds, acute limb ischemia, myocardial infarction, stroke, or hospital transfers within 72 hours. Minor complications did occur in 0.5%. This study showed that it is safe to perform minimally invasive, non-complex vascular interventions in patients with low to moderate cardiovascular procedural risk in an office-based lab. The final article and our CME article this month by Paulus and co-authors is Temporary Intravascular Shunt Improves the Early Limb Salvage After Extremity Vascular Surgery. This is a study done in patients with vascular injury, often crush injuries to the limb. The authors report on civilian patients who sustained a severe extremity vascular injury. Patients who had TIVS, that is the shunt, were compared to those who were treated without TIVS or without the shunt. There were 78 patients from 24 trauma centers who had a shunt used, and a control group of 613 patients. The shunt group was more severely injured and had more severely mangled extremities, but the non-shunt group had a 3-time greater likelihood of amputation. Concomitant nerve injury and orthopedic fractures were associated with a greater risk of amputations. The authors concluded that shunts expedite limb perfusion and result in lower rates of amputation. They should be part of an aggressive approach to restore perfusion in injured patients with ischemic limbs. Thank you for watching. For more information, please follow us on social media and remember to like, comment, and share. We hope that you enjoy these 4 highlighted papers and the other excellent papers in this month's Journal of Vascular Surgery. Remember that these articles are free to read until the end of June. And thank you for your attention.